Joanna Macy, the great environmental activist and systems ecologist, said that when faced with planetary crisis, there are three stories we can tell ourselves. Business as usual, in which we tell ourselves that some degree of damage is necessary for human progress. The great unraveling, in which we tell ourselves that mass ecosystem destruction is inevitable. And the great turning, in which we tell ourselves that evolving the way we live is the only way forward, and that we're at the beginning of one of the great projects in human history. On this podcast, we talk to people who are writing that third story, with their own work and their own lives. Mission-driven leaders who are dedicated to social and environmental impact at this critical moment for our species. Welcome to The Turning Point. So Ian Williams and I have been having an internal debate here at the Turning Point podcast about whether to bring on guests from the healthcare space. And so we're all about social impact. We have clients in the space. And in the end, I was thinking, Ian, why do we even care about things like decarbonization and healthy food systems? And it's because it directly affects people's health and well-being, right? So did I summarize that discussion well?
I think that is an accurate summation, and I think it's a two-way street, right? Decarbonization, climate impacts human well-being, and also human well-being and social impacts. Social impact affects our ability to impact the climate positively.
Right. So ultimately, we decided it was a good idea. So over the next few weeks, we're going to be posting a few interviews with founders in the healthcare space, people who are making a pretty direct impact and immediate impact on human health. So today's guest is Mike Pitt. He's the founder of a company called Q-Rounds. And what they've done is they've solved the seemingly intractable problem of syncing up doctors, nurses, patients, families, translators, everybody's schedules so that when the doctor makes the rounds, they can actually all get there reliably at the same time. And apparently this is a huge problem in healthcare, and it has a big impact on outcomes in a lot of different areas. So, and I know this solution really resonated with you, Ian, because it sits right at that intersection that we like to talk about of people, process, and purpose.
Yeah, this is one of those really elegant solutions that sits at the middle of a complex problem. And one of the things that we talk about with clients all the time is this minimum effective dose, right? Like, what is the least amount of effort required to have the desired amount of change? Mm-hmm. And, this is a software solution of all things that is really, again, improving people's lives and improving health outcomes. So super excited about it.
Yeah, it was one of those solutions that almost felt too good to be true. Is like, I felt like half of the questions we ended up asking him is, why didn't anybody do this before? The impacts are so positive across the board for everyone. It's such a win-win-win. Like, why did this not happen before? And I think it's a great story of why complex systems are difficult to change and why it takes unusual founders like Mike Pitt to come up with these elegant solutions. So yeah, we're really excited to introduce more people to Mike Pitt and Q-Rounds and spread the word about the great work they're doing, and hope everybody enjoys. Mike Pitt, welcome to The Turning Point.
Thanks for having me.
Yeah, really glad to have you here. Really excited to learn more about Q-Rounds. So, to get right into it, can you tell us about the problem that Q-Rounds is solving? Like how you became aware of it and what got you motivated to work on this problem?
Yeah, it's a unique story because I got to know it from all sides of the table. So I'm a pediatric hospitalist. That means I take care of kids that are sick enough to be in the hospital. It also means I see those pain points well from my lens. What is it like to be the doctor that's showing up to meet with the patient every day for what's called that most important discussion? It's called rounds. When the doctor shows up, ideally is meeting with the patient, the nurse, the family of the patient, often an interpreter. And I would often feel what it was like to show up to an empty room or just have the patient and not have the family or have to find the nurse. So I felt that pain point of care coordination personally. But then I experienced it as a loved one. Over a long stretch, we had multiple parents in the hospital, and I was often across the country, the person they would call when the doctors entered the room or ask the doctors to call me. And I spent meetings for months saying, I'm going to get a phone call between 7 a.m. at noon, and I'm going to have to drop what I'm doing to enter that conversation. I'm sitting in a Great Clips waiting room getting text that says, you're 4 away for your haircut, you're 3 away from your haircut, and realizing if they can respect my time enough to tell me when I can be there, or I can track my pizza, or I can do any of these things, why are we not doing that in healthcare? And so aimed to solve that problem of getting all of the stakeholders in the room for that most important discussion with what we call time transparency, the same thing we expect from Domino's or DoorDash in healthcare.
So does Great Clips know that you stole their brilliant idea?
I've mentioned I should at least be getting free haircuts. At some point, I'd love to partner with them, but they have a nonprofit, and I'd love to have them help us bring this into more NICUs in the state as we built this out.
Yeah, I love that insight, and I love when domains cross like that. So when I hear stories like that, it makes me wonder, right? Of course, we can all think of examples where there's, a service where it's impossible to figure out when you're going to get the service, right? Like the cable guy is probably the canonical example. And obviously, there are a lot of people like you who've had experiences with hospital care where they've had that very frustrating experience too. And it just makes me wonder, why can Great Clips and Domino's figure this out? And why is it so hard for this to be figured out in the hospital setting?
Yeah, what's beautiful about the Q round story, and just to really finish out what it is, what we do now and are live in multiple hospital systems, families, when the doctors create that rounding list in Q rounds of the order they're going to see patients, and we provide insights on the best order to see patients, the sickest patients, nurse assignments, et cetera, pulling all from the electronic health record. When they drag and drop that into the order they're going to see patients, families start to receive real-time updates. You're six to be seen, you're next to be seen, and they're able to RSVP to join rounds remotely if they can't be there in person. We've just passed 35,000 families that have joined rounds just in Minnesota that way that wouldn't have been able to be there otherwise. And so now when the doctor enters that room, when the family's not there, with one click, the family's pulled on the line and the interpreter if necessary. So we've really automated that multidisciplinary rounding experience. But to your point, when we would tell people this story, they'd say, oh my gosh, I absolutely needed that. I was held hostage at the bedside for my mom, or I couldn't get a cup of coffee or go to the bathroom for fear of missing that most important discussion. How does this not exist already? We didn't even need an elevator ride for the elevator pitch. We could do it on an escalator and people would go, oh my gosh, I've needed that my whole life. The answer to that question, all of those other things that we're talking about where time transparency exists, my package, the DoorDash, the haircut, the Starbucks order, those are linear transactions. Some list is created and you are just marching through the queue. In healthcare, instead, unlike a package that's loaded on a truck, things burst into flames. New urgencies come out. I have to change the order. I don't just get to fix in real time. And the complexities of a nurse who's occupied and a family that doesn't speak English, all of that made it that I believe people might have thought of this, started it, and said, this is too complicated. We had the beauty of being laser focused on this problem, solving it in spades, and then being able to move on to other areas in the hospital where time transparency is needed.
Okay, so if I can try my best to interpret that, there's just a lot of complexity in the process of medical professionals making rounds. And
yeah, unlike that package that's put on a truck that's going to get from house A and then it's going to go to house B and C, all of a sudden you need to shuffle the house order because somebody gets sick. Or all of a sudden your plans change because you have to get called to a code in the emergency department. And we needed to be able to solve for all of that nuance, and we're dedicated to doing that.
okay, from the way you explained it, this is something that was too much complexity for the hospital unit to solve themselves, or for the healthcare unit to solve themselves.
Yeah, this is the complaint we hear the most from families. The number one question in the hospital is, when will the doctor be here? It's asked every single day. It's not just nice to know that answer, it leads to better outcomes when you know it. We know that when the nurse knows the answer to that question and they are able to join the doctor at the bedside for rounds, medical errors drop by 40%. Just eliminating that telephone game by being in the room at the same time improves health outcomes, just in that single example. So we knew people cared about this. They wanted to solve it. And they've just said we had given up on a solution until we saw what Q rounds could do.
Okay, well, now I'm dying to know, how did you solve this problem?
So I had the Great Clips experience. I met with a colleague at the University of Minnesota. I'm a professor there, and he's a professor in electrical and computer engineering. We met for Korean in Dinkytown, and I said, could you build the Great Clips app for healthcare if we got some funding? So we started with a grant. We got a $5,000 grant to build out a proof of concept. It did not talk to the electronic health record. It was kind of a manual, clunky process. But we knew we were onto something when that process was implemented during during COVID, and we had families that weren't able to be at the bedside, physically not allowed to be in the hospital, were now able to join rounds. We had med students that were not allowed in the hospital because there wasn't enough PPE, personal protective equipment. They were now joining and triangulated at the bedside, even with this clunky EHR agnostic thing. And people were saying, you're on to something here. And that's where we did a small fundraise to be able to actually do that EHR integration, partnered with Fairview, and went live there over 2 years ago.
So, Mike, I definitely want to dive into the grant funding because that was actually one thing that I found pretty unique about the insights when I saw you speak. But I'm wondering if we can jump back one step in the conversation. You said that health outcomes can improve 40% when the doctor and the nurse are in the same room at the same time. Could you also give us a sense of like the economic cost of what are the implications economically for a hospital with trying to coordinate all these different providers with the patients and their families?
Yeah, so there's really three main areas that we are going to see an impact on ROI. So one is that error reduction, malpractice claims, things that are all upstream related to communication. When we don't get the people in the room talking, we make errors. And so we see error reduction. Those are costly, both in a physical sense. It's a major cause of death in the United States is medical errors in a hospital system. And they're hard dollars when that actually manifests into lawsuits for hospitals and having to undo the mistake that's been made with other healthcare decisions. So one is that error reduction we're able to see. Two is length of stay. When we identify barriers to discharge, when we have the family present saying, okay, this is what we need to go home, and they're on the same page, we can get patients out of the hospital to their homes faster and make it less likely that they have to bounce back to the hospital because they actually understood the plan, because you weren't relying on the sick patient to be the message giver of how they're going to cared for. You had the family present throughout that discussion. So we can see beds turnover faster as well as less likely to be readmitted. And then there's patient engagement. This is not just, the patient experience is not just a nice to have. There are dollars that are withheld for top box scores and patient experience. One of those survey questions is, did my doctor update me every day? We get that to 100%. And those dollars get recouped by hospitals. But there's also just market effects. If I'm at a hospital that shows me the dignity that they are going to include my family and tell me when the same dignity that Domino's is giving me, we're going to give from the healthcare team, that is a competitive advantage in the healthcare space. So that leads to revenue there. That's just kind of the big three we talk about. We're seeing things around nurse engagement. Nurses are telling us that the doctors are learning their names for the first time because nurses get notified to be automatically included in rounds. And the doctor's able to see, oh, Mia is on her way, as opposed to hoping the name tag is facing the right way. So just that sense of community in healthcare, of us working as a team, we're seeing benefits in there, and we expect that to manifest as lower turnover and increased retention in that competitive nursing landscape.
That's incredible. Just the level of dignity that Domino's shows us.
Exactly.
Yeah.
Now, it's funny, you brought that up. Our CTO likes to tell the story that Domino's pizza tracker, which we use as an example, is also a lot of hand waving, meaning it's not telling you that they're putting the pepperoni. Nobody's manually saying each step of the pizza. Once that starts, for the most part, it's kind of projecting how long it usually takes to make a pizza, and then the next update is from the car. And even now that I know that I'm being lied to, it still was satisfying when we were ordering Domino's over for trick-or-treaters, for our family on Halloween. So we are actually giving time transparency where it's real time. I know, and families don't come to view these as appointments. They're not saying, oh, the doctor is late. They're getting kept in the loop and able to pivot their plans accordingly, to join remotely if they couldn't have wait any longer in the hospital. I met with some doctors the other day showing them Q rounds, and they said, well, I'm worried I'd be letting the family down if I was late. And I said, I hate to tell you this, we're letting the family down already. Our standard of care is letting the family down. They're held hostage, afraid to leave the room, and we are now giving them the gift of expectation.
Yeah. Like you said, even imperfect transparency beats being completely in the dark.
Absolutely.
Absolutely. So on that note, I'd love if you could give us a little bit of a user's eye view of what it's like to use Q rounds.
Yeah, and I would say the secret sauce, as you think about these different stakeholders of why we've been successful, is every user thinks we were invented to solve their problem. That is very rare in healthcare. Usually, as a doctor, if you're asking me to click some buttons, I'm doing it to make somebody else's life better. And if we have solved something where what I'm the most proud of, we've not had a day we've been live in the NICU at Masonic that a doctor has chosen not to use Q rounds. Once it's on, they've used it every single day. So the three stakeholders to really think of in this, we're going to talk about the doctor, the nurse, and the family of the patient. Again, in pediatrics, this is particularly unique. If a baby is in the room and the family's not there, we don't get to say to the 1-year-old, okay, tell your mom and dad what we talked about, right? I have to get them involved, and that inefficiency is baked into my day already. We've solved for that. So what the doctor does is they log into Q Rounds. It's in the app store or on their hospital device. It pulls their patient list from the electronic health record of the patients they already have to see. It suggests a rounding order for them, including things like who's going to be discharged today, who's the sickest patient, what nurse assignments, who needs an interpreter. They're able to drag and drop into the order they want to see patients and hit share. That process takes about 41 seconds. I do it in the line at Starbucks on the way into the hospital. So I share my list. Once that gets sent out, three things happen. Every nurse gets pinged on their hospital device. These are devices they already have. We didn't want nurses to have to learn something, download an app, log in, remember a password. It's going to what they already receive. Dr. Pitt shared his rounding queue. You have 3 patients on the queue. Your first is at 10:15 in room 74. So they get a notification. Second, it goes to the electronic health record, so everybody can see that rounding queue in real time. That's where things like social workers, care coordinators, discharge pharmacists are relying on that to be able to join the team at the right time. But the game changer is the family. If you've ever been at a hotel and gotten a text that your room was ready, or from your flight that your flight was delayed, families receive a text message in the morning that the rounding queue has been shared. They click in, they see a dashboard that shows them when they're expected to be seen, their queue position, and the ability to RSVP. Call me, not today. We're actually just doing a partner where they can join virtually and they'll pop up on the television screen if that hospital's enabled for that when we walk in the room. So families RSVP, they can invite additional families. We integrate with your interpreter system. So now when I'm ready to round, anytime I hit next, everything updates downstream. The nurse is notified to meet me at the room. The family gets a text, we're on their way. And if they've RSVP'd to join remotely, when I look at my app, that start call button is lit up and blinking. And with one click, I press that button, my phone rings, dad's phone rings, and if necessary, an interpreter's on the line. So that's how we've had almost 35,000 families join remotely via that approach.
Okay, thanks. I love that description. That's really vivid. Thank you. So I think I see how this is working from the user's perspective. Now, give me an example of what happens when something happens to the doctor's rounds. Like one of those fires happens, somebody's sick, something has to change. How does that filter through this user experience?
Yeah, so anybody with access to the queue can pause it. So if something comes up, I get pulled in a direction, pause. Every family gets downstream, gets a message that rounds have been paused and you'll be kept in the loop when they resume. The nurses are able to see that in the sight line. So again, right now, all of a sudden, they're just not there and people don't know where they are. This is actually keeping everybody in the loop in that process. And because it's a hospital where families understand that patients are sick and things come up, there's a lot of grace in that. We have just seen in our most recent go live that we're within 19 minutes of that estimated rounding time is the average. So we're still landing in that window, but that transparency of real time pausing notifications changes is a key.
Yeah, this is right in my wheelhouse, Mike. Someone who is both a psychology and a human factors doctorate. I think people underestimate, to your point, the value of any level of transparency versus knowing nothing, right?
Absolutely. And you know, we've seen this in those other industries. The cable guy window of it used to be 8 to 4, and now we at least get the dispatch text that they're on their way, and you can start to plan accordingly. I had a situation this week where somebody from the irrigation blowout I didn't get those notifications. I didn't know they were coming. I was in a meeting. They walked in the house and my dog chased them down and lost their mind because they let themselves in the house to do it. So, you know, just that ability to be getting the real-time update on anything has become kind of table stakes in every arena about healthcare.
Yeah. Justin, I know you're going somewhere with this, but I want to pause here because I feel like it's an important part of the conversation and it makes sense contextually. Mike, you've talked about patient outcomes improving. We've talked a little bit about the economics, but one thing that I'm starting to perceive with a little bit more nuance and clarity now is also I'm imagining that this has a huge impact on like job satisfaction, team cohesion for the care team. Because one of the things that we experience all the time as external consultants is it's just a lack of information being shared internally, and it's kind of a siloed effect within the organization. And if we can break down those silos, we can put everybody's expertise to use and solve the complex problems together. You're already doing that as a care team, solving complex problems, but it sounds like you're solving this really huge internal thing that might be challenging to either label or address through a traditional external intervention, for lack of a better term. Could you talk about some of the wins that you've seen with the care teams themselves and like what's happening for employee engagement, job satisfaction, things like that?
Yeah, almost every healthcare care worker's origin story involves watching a television show about healthcare. There's the Grey's Anatomy generation. I was the ER generation. And if they showed what it actually meant to do that work, none of us would have got into healthcare. If there was an episode where George Clooney sat on the phone with an insurance company doing prior authorization or trying to find the nurse, that would have not been very appealing for most of us. And so I think there's this reality when you get in and go, oh my goodness, it is a administrative job. Like so much of my work is tracking people down and finding people. And so when we take the cognitive load away from that, and all of a sudden you are just walking from room to room, and the nurses are there, and the interpreter's there, and the family's there, and you get to do and make eye contact and do what you wanted to do in the first place, that is very meaningful. And I collect the text messages of colleagues who were skeptical. Doctors like, oh, this isn't going to work for me. I've done it this way forever. And then they go, you know what? I saw 7 additional family members yesterday that I'd not met. Rounds finish faster. This is what I went into medicine to do. And so I absolutely believe the burnout vaccine of eye contact and what we wanted to do as opposed to staring at a screen or sitting on a phone on hold is a huge part of this. And it really makes for those meaningful connections where the nurse, it is a standard of care for the nurse to join the doctor at the bedside for rounds. It happens about 5% of the time. We are consistently seeing 80 to 90% once we go live. So we're again, all of a sudden you're making connections and you're meeting colleagues that you've worked with for 15 years where it matters at the bedside.
It's awesome. Speaking our language, Mike. So I'm going to shift gears just a little bit into kind of the business side of things. We talk to a lot of entrepreneurs and founders who have great ideas, but then there's bringing it to the market in a successful way. So can you talk to us a little bit about some of the business challenges you're facing with what is obviously a very impactful idea, but actually getting it to market?
Yeah, there's several. One is this is mission driven. This was not an entrepreneur in search of an idea. I don't even really identify with the word entrepreneur, though I have a newfound respect for how big that job is if you're successful, meaning you've done 50 different job descriptions of work to get there. So, which I didn't understand before, but I still view myself as I just was trying to solve a problem something that annoyed me. That's, I think, the best origin story for things, and it felt like an injustice. What I've had to learn is doing the right thing is not enough in healthcare. Everybody understands that, oh my gosh, the family should have this is a game changer for families, but it is a finite resource field and they have to choose where to allocate funding to. So I've had to learn to go from, come on, this is the right thing to do. It's like my vision was just kindness, really. I mean, it was doing the thing that you would want for your parent or loved one to say, oh no, we actually have to show an ROI. We have to show that this is going to move the needle on things that a hospital system cares for. So that was a growth for me, is it's not good enough to be nice and kind. It has to actually do things that they're already trying to do. And luckily we are. So that helps with that story. The other thing that we have an advantage in is I think a lot of healthcare startups have a single buyer. If you're making an EKG algorithm, you're going to have to go and get the champion in cardiology. Every human being that works at the hospital can be a champion for us because they go, oh, I needed this when my kid was in the NICU. So we have the heartstring ability to get to lots of champions, but also there are offices that are focused on some of the KPIs that we move. So we have some of our sites are coming in through their patient experience office, and they're just saying we're focused on the fact that we need to improve our numbers on patient engagement and experience, and we can do that. We have others that were going in through their AI office and they're saying, we're trying to be the leaders in innovation and technology. This is a game changer. How do you help us do this? And then we have others that are doing it from just the clinical need. They're solving it from an experience they feel as doctors on a team. I think that's a unique position for us to have multiple entry points. Now, it doesn't change the long healthcare sales cycle in healthcare. And so we're navigating that. And I think starting to see the fruition of kind of those longer relationships.
Yeah, and just out of curiosity, I know your expertise is in pediatrics. Is that mainly where Q Rounds is being adopted right now?
So we're starting there. That's our go-to-market is in pediatrics. It's in neonatal intensive care units in particular because you've got families that are they're often in the NICU for 3 to 5 months. So people are back to work and they have to choose between keeping a job or being present for rounds. And we have been able to solve for that and get those families there. So we're in the neonatal intensive care units. We're currently in Rochester in their pediatric ICU, CV ICU, and NICUs as well. And we actually had one of the moms the very first day we went live in the cardiac intensive care unit. There was a mom of a child that's been there for 5 months waiting for a heart transplant. And that doctor was actually a bit skeptical of the value Q Rounds would provide. This was the very first day of go live. And when she hit that button next that told the next family we were coming, that mom ran down the hall because she was in a work meeting in a conference room to join rounds. And they told that child that he would be able to come off dialysis that day and walk the hospital for the first time in months. And the mom had tears in her eyes and she said, this is Christmas morning to me. How could I have missed this? Thank God for whatever this thing was that just texted me to come because it was new to her. And you saw every person had tears in their eyes on round. It was a meaning again that not only was the mom robbed of that connection, but the social worker, all of us got to benefit and were better from it. And I watched the doctor realize like, wow, there's a lot of power in hitting a button in what that can do.
I mean, we talk to a lot of people who are advancing technological solutions, but to see that connection between, like you said, hitting a button and an emotional Christmas morning for a mom,
Right.
that must be incredibly rewarding for you.
Yeah, it was I think founders are not very good at celebrating wins. And I tell that story just as much to keep it in my front of my brain because it was a powerful moment. And our team doesn't always get to be in the hospital and see those moments. I was giving a talk at a luncheon for a nonprofit I work with called Jack's Basket that celebrates children with Down syndrome. And I do a lot of communication work and it's training doctors how to not frame that diagnosis as bad news, but unexpected news. At this, it was a neonatal Fairview nurse practitioner neonatal luncheon, and when they introduced me, they said, "Oh, you might know Dr. Pitt as the one that brought us Q Rounds." And the whole luncheon room burst into applause. These were all nurse practitioners that have used this. And that was another moment. I'm like, that is weird. Healthcare tech does not generate spontaneous applause when they find out you're the one that did it. And again, those two stories, that's a patient telling me how it changed their life, and now these frontline providers.
Yeah. So I'm just curious, as an entrepreneur, do you have a hard time staying grounded in your original motivation while you're busy with the day-to-day of trying to grow the startup?
I might say it's the opposite. I am so mission driven that I sometimes forget that the goal for a company is growth, not just these wins and kind of the pace. So I think sometimes I have to remind myself that I'm the CEO and need to help grow the company beyond just collecting these individual meaningful stories. So there's no such thing as mission driven to a fault. I mean, maybe there is. We could probably have a conversation about that. But I think sometimes that mission driven part, it makes it hard for me, for example, to get motivated as an entrepreneur by what the traditional entrepreneur motivation is. Like, what is the exit? What is this? I have to remind myself I need to think about that because we have investors and a team, but it's not at the forefront of my daydreams at all.
So, Mike, one thing that I found was really interesting when I saw you, at the Groove Pitch series was you have secured, I think I read over $2 million in grant funding, and I think it's a unique financial strategy, but I also think it's one that's probably not necessarily as well known as it could or should be. Right? I think when people think entrepreneurs, they think I need to go find a venture capitalist, I need to go find investors, and you've raised a significant amount of money in grant funding alone. I'm curious if you could just maybe speak to like why or how you were so successful in doing that. And then if you have Any tips, tricks, advice for others who are needing capital in order to grow their mission-driven startup and aren't necessarily aware that grant funding is even an option?
Yeah, well, the first why was because it was what I knew how to do. I was a professor, I'm a researcher. I've secured grants where you basically are pitching an idea to a VC of sorts, a funder that has this purse strings of a grant, and you're saying, here, give me this money and I will do this, execute this vision. So really in a way, grant funded researchers are quite primed to play the game of entrepreneurship and the VC side because you have to tell the story and convince people to give you money to do something. So it started with some internal funding, but I learned, and I'll give a shout out to Pat Dillon and the Minnesota SBIR group. It's a nonprofit in the state that helps people navigate this very question. But specifically, the SBIR funding, which is currently on pause for new applications, not just because of the shutdown, but it needs to be reauthorized. Everybody expects it to. But it's a government funding through called Small Business Innovation Research Fund. And you're able to say, I have an idea. They have calls for proposals that can come from the Department of Defense or the NIH, like they can come from each organization. And you say, like, I have both the skill set and idea to solve this problem, or it could be a more generic call for proposals. And that was something, again, I knew how to write grants. And so we applied for that. And that is $2.2 million in non-dilutive funding to really do things that were on our roadmap anyway. So it became kind of the developmental funding that's going to solve the problems that we promised, but also were things that we were planning on in the first place. So it absolutely has been a game changer for us to then be able to raise less of dilutive capital and be able to focus on growing with a pipeline of funding that we expect to renew. There's multiple opportunities. If you get one SBIR grant, you're something like 30 times more likely to get another one. So we plan on continually applying for those.
Awesome.
Yeah, it's funny in academia, of course, people are so accustomed to the grant game. And I hadn't thought about that analogy of like, of course it primes you for entrepreneurship.
Well, and I think the rejection resilience primes you.
Right.
Like it doesn't sting to get rejected. Whereas I think a lot of people are like, it just is crushing. But like academics, most times I submit a paper, I've published over 100 peer-reviewed papers. Most of the time it's not accepted by the first journal. So you just kind of polish and move on to the next. And we've seen that play out with colleagues that are more stung by rejection than I think John and I, as the original co-founders here, Chelsea's but John was in academics too, so he doesn't bristle with that rejection at all.
Yeah, your pride gets shuttled before you even get your terminal degree.
And I think it also primes you to understand feedback. It's not just that I don't get stung because I think, well, joke's on you, you don't know what you're talking about. You learn to take the feedback, and the feedback is right. Feedback is always right. It's right because it's an emotion. It's coming from somebody's own experience, and for whatever reason, your thing didn't land because of X. You should always be listening to what that X is and not cross your arms and say morons didn't get it. I've really learned to take feedback as truth.
So does the appreciation for feedback and comfort with it, does that apply to how you've developed the Q Rounds technology too?
Yeah, absolutely. So like when we're hearing things from users and consumers, I think the one place we did put some boundaries on that feedback is knowing that like our goal is to solve this problem first of getting everybody in the room at the same time. And feature creep can grow. Oh my gosh, what if it could do this? What if it could do this? And every what if it could do this required the doctor to have to think about something. And we wanted to keep the cognitive load. You're already saying what order you're going to see patients in. We're just asking you to hit a button. And so we've had to resist or at least put on the parking lot some features that would actually create some complication to workflow. Just as an example, one of the things I hear every time we pitch is, oh, well, what if a nurse is busy when it's their turn? Can they tell the doctor to see another patient at a different? And what we did not want to do is the doctor to get inundated with that time's not going to work. We just go back to the current standard of care right now as they're walking in a room and trying to call the nurse if they can read the handwriting and remember, on the board to call them. And that nurse is going to have to drop what they're doing to show up or send someone else. Now we give them a sight line. So if the nurse is going to be occupied, they can at least ask the charge nurse to go in their place. But just as an example, one boundary we've put on things is if it's going to complicate things for the doctor, no matter how great an idea it is, it won't get used. And so we put some boundaries there.
Yeah, I appreciate you've mentioned the term cognitive load 2 or 3 times. I think it's so underappreciated when developing any kind of new innovation into a complex space.
Right. I had somebody come up at a table when we were doing one of the booths that we've done at a NICU conference, and they just said, how did a business actually solve this? And I didn't appreciate that at the time, but they were saying that so often you don't have clinician leads that actually know the problem. And my biggest add to the product type of things is going, that'll never work. Like is just the quick no. So we can fail. We're not even failing fast. We're not even putting it on the table. Whereas I think if you were just coming in as an entrepreneur, even with an advisor, you
Yeah.
might not get there. You'd go down too far.
Yep.
Yeah.
Yeah. I mean, yes, adoption is so difficult with anything new in a complex environment. And I can see, like, every story you tell, I can see how you're emphasizing that. And man, that's such a difference maker in my experience.
For
Yeah.
sure.
So I'd love to pivot, if we can, a little more to you as a person and like what unique background you bring to this space. So not to put you in a box or anything, Mike, but we've repeatedly observed that the most innovative entrepreneurs, and not just innovative, but people who are able to come up with integrated solutions, we call them rangy players. They're people who bring a lot of different backgrounds into a space and often unexpected backgrounds. So can you tell us about who you are and how you're a little different in this space?
Yeah, I think the two things that would make me a little different in my origin into healthcare first is I grew up doing magic professionally. I did magic 4 nights a week in restaurants and trade shows across the country, paid my way through medical school as a magician, and knew early on that as I would volunteer in the hospital doing magic for kids, that I'd always hear about the art of medicine, the art of medicine. And I realized that like that is a performance art. There is an expectation to what that, and I think some of it again is the doctor on television, right? Of what that performance looks like. And so I became very interested in kind of how can you could be the smartest doctor in the world, but if you weren't communicating effectively with patients and they didn't understand what you were doing, you were useless. And so early on, I knew that magic was going to be part of my medicine story forever. I still teach magic across the country to pediatricians, not just how they can increase their rapport with pediatric patients, but how they can learn to think like a magician. Magicians use misdirection. I get you to pay attention to this while I'm doing something else. That is the best skill for a pediatrician to learn to master. So I teach kind of how to use misdirection, how to use magician's force. Force is the concept of making it feel like you have a free choice at something by selecting a card, for example, but I am still in charge. And there a simple example in pediatrics that I teach and use this. If you need to look in a kid's ear, if you ask a yes or no question, can I look in your ear? That is a yes or no question. If they say no, you're kind of screwed because you still need to look in their ear. But if you say, which ear should I look in first? You give the perception of choice. It doesn't feel like a force. And they say, right. And now I get to listen to look in both ears. Or if I'm examining a kid's belly, I know that if I put my hand on their belly and it's constipation, they're going to clamp down. It's going to be really hard to know if it's appendicitis or not. But if I start with my stethoscope and say, I'm going to take a listen to your belly to figure out what you had for breakfast, and I go to where their appendix is and I press as hard as I can, they're not thinking this is the part where they're feeling my belly. They're thinking I'm listening, and I can gather a lot of information under the guise of that. So just teaching what does misdirection look like, pattern, how we communicate look like. As a magician, I always dreamed of starting a talk by doing a magic trick and then teaching the doctors how to do the trick but using magician jargon. And I do this now. I've done this talk up probably 500 times. I start the talk by doing a trick. I can do it for you in a second if you'd like, where I do the trick and then I teach them how to do it, but I use magician's jargon. And I say to them afterwards, if I just taught you to do that trick, if you can't pick up a deck of cards tonight and do that trick, then you're non-compliant, which in medical language means you didn't do what I told you to, which is how doctors say they did. And it's a powerful moment for that audience to go. I say, we do this to patients all the time. We think we've told them, but we're using words and phrases they don't understand. And then we're frustrated when they don't carry out the plan. That's on us. We didn't teach them to do the card trick. So magic has been a huge part of my life. It's a huge part. I believe unused creativity is malignant. And so I think I know if I'm not daydreaming about magic every now and then, I'm in a bad place. And so I think that if that is a lesson for anybody, if you've got something in that space. And then the second part that I think makes me unique in that origin story is I majored in English because of this, because I knew I could learn the science, but I wanted to actually learn how to effectively communicate and study that. And I've since published, over a dozen papers on how doctors can learn to communicate more effectively and eliminate jargon, for example.
Huh. So thanks for the magic story, and I wouldn't mind learning a trick at all while we're on here.
Absolutely. Yeah,
Here,
absolutely.
I'll show you the trick that I do. It's a classic trick. It works well over Zoom. This is an invisible deck of playing cards. Either Justin or Ian, one of you are going to reach through the screen and grab out a card for me.
Okay.
Okay, Ian was first. Justin got one. We can use either one. Both look at your card. Make sure you've actually thought of one so that we can highlight that it's people think of different cards. And I'm going to take a different color invisible deck. They make red and blue. You can put your cards face up into this deck for me. We'll just choose one of them, but this way people know that we're not doing it. Or Ian's went in first. Ian, this is going to represent that deck of cards. What was the card that you looked at?
Eight of diamonds.
Eight of diamonds. Do you remember? I told you when you put it in the deck to put it face up.
Correct.
So for those that are listening, I'm fanning through a card, and the only face-up card is the Eight of Diamonds. I also told you it was from a different color deck. That's the only one that came from that red deck of cards. So I do this trick, and then I tell everybody, of course, this is a version of the ultra mental principle popularized by the brainwave in the Marlowe School in Chicago in the 50s, using a full deck stack on the chase method, which allows me to reveal the rough cards on the 7. Now that I taught you how to do that trick, blah, blah, blah. But again, I just did it with magician's jargons. The magicians that might be listening to this would be annoyed that I just revealed that. But to any other person, they're completely in the dark, which sadly is what we do as doctors all the time. We coined the phrase jargon oblivion to highlight the mismatch between doctors' intent to speak clearly and the fact that most people don't understand what they're saying.
Okay, so tell me how some of that magician wisdom applies to Q rounds.
Well, again, it goes back to the core mission is people need to have a seat at the table to be able to understand their healthcare. And from an equity and standpoint, when we only talk to the family that's in the room, we are missing out on people who can't afford. They have 2 jobs. They have other kids that can't afford to be there. We want to make access to rounds a right as opposed to a privilege for those that can afford to be sitting there. And so the core of that mission comes from that sense that communication and how we interact starts with the seat at the table. And again, that magician as teacher for me has always been a part of this, that a lot of doctors when they were growing up say, oh, I want to be a doctor or a teacher. You are both. You are not an effective doctor unless you're a teacher. And so if we can get people in the room virtually or otherwise, we have the ability to transform outcomes.
Yeah, and I think what sits with me most after all of this conversation is the connection you're making between care, the technical aspect of care, and the human aspect of care. And you hear people talk about that disconnection in healthcare a lot, but you've actually come up with a technical solution that brings the human side and the technical side together. And that seems to me really, really powerful.
Yeah, I think that's an exciting season we're seeing in healthcare tech. Some of the ambient scribing technology that's allowing people to just have a conversation and have a note generated rather than typing in a computer screen like a secretary and not making eye contact with the patient. I think that's what's going to be exciting in this kind of new wave of healthcare technology, is what allows you to do what separates us from AI, from an unskilled worker, what allows us to practice at the top of our license with patients.
Yeah, and it makes me wonder, and feel free to decline this question, but where do you see Q rounds going in 5 or 10 years? I mean, it seems like to me this platform is solving a very generalizable problem, and it seems like it has a lot of legs in terms of what else it could be doing to improve the care experience.
For sure, that time transparency is a moment that happens not just during rounds, but it happens when you're in the clinic. So if you have a parent, for example, that was at an Alzheimer's appointment and you were saying, please call me when the doctor enters the room, that call's likely not to happen. We can bring that same experience into clinic experiences so families can join and participate when it's relevant. There's also, the number one question I mentioned is, when will the doctor be here? The number 2 question is, do you guys even talk to each other? Meaning, does the cardiologist talk with the surgeon? The family is hearing these different stories as they come in the room or they get invited. One of the things on our roadmap for next year is really optimizing that provider circle of getting all the other doctors in the room at the same time, or the ability to pull in a consultant virtually. In the state of Wyoming, there is one rheumatologist in the entire state. So if there are many places where you are in complete deserts of expertise. We can actually pull that consultant into the room for that rounding discussion. They can generate a billable consult for that, and we've solved a problem there. So we have lots of things that we're excited about as we roll that out. Provider circle being one, as well as the outside of the hospital Q rounds experience.
I just want to preface it though with Mike, like all of these conversations are enjoyable, but this one has been particularly enjoyable. Having spent the first part of my career in education and the first 5 years of that in early childhood, so many of the skills that you're talking about in terms of what makes you an effective care provider, I think are very translatable to I'd like to think I was an effective educator. And a lot of those skills transition into the work that we're doing now too, right? It's how do we break down these barriers and how do we communicate and, for lack of a better term, teach in a way that the student can actually hear it. And I think that skill set and domain and expertise paired with this really elegant technical solution to a pretty complex adaptive challenge is it's a wonderful stew of a lot of really meaningful stuff. And so I'm excited to follow Q rounds as you all grow and continue to have an impact. One thing, so we always try and wrap with a few common questions, and this one isn't a question, it's really asking for a piece of advice selfishly for the other mission-driven founders who are listening. What is one piece of advice that you have for other mission-driven founders who are trying to build their own organization?
Yeah, we talked about this a little bit earlier, but it's that sense of don't lose sight of the mission, but also don't let the mission keep you from creating a business that can grow. And I think that it's that sense of that mission as true north is a core, and it has to have product market fit and be able to do all those other things. Otherwise you're in that nonprofit sector. And so what does it look? And again, for us, there was a thought, should this be a nonprofit? Should we figure out how to do this? And the short answer was there aren't really examples of hospitals integrating technologies with nonprofits. So it really needed to actually have the structure of a company. But I think it's that stay mission driven with the asterisk that you have to make sure that you can actually plug that mission into the workspace, which has been an adjustment for me.
Yeah. Okay. And then we always try and wrap with the same two questions. So I'll start being the systems nerd on this team between the two of us. What is the highest leverage system level change that you think would help improve this patient-provider coordination process?
I think it really is just automating the expectation that information exchange is the most important part of healthcare decision making. It's not what your lab shows. So bringing everybody to the table and really automating that is, again, it's a best practice that nobody does. We're excited to actually make it an achievable best practice. And so I think that expectation that the nurse will be there, we've had that play out where we go live and it was 5% of the time the nurses have been present. They're going to 80%, but there's a little bit of change management to that. They want me there, So I think getting it to the place where it is so expected. I think right now that I tell residents that when you leave the room, a family, this is without Q rounds, when you leave the room and you've updated a family, that they're going to pick up the phone and call somebody and say, the doctors were just here. This is what they're thinking. And how much better is it if we're able to actually get the people for that conversation there, make that conversation make sense? So yeah, I'm excited about watching that become the standard of care, and that is going to require some change management for sure.
Yeah. And speaking of change management, Mike, is there something on the individual level, whether it's a behavior change or a mindset shift, that would make a big difference with certain individuals?
So in pediatrics, it's easy because everybody has to update that parent. It is built into the workflow. If you have had an adult loved one hospitalized in your life, you know that that's not necessarily the expectation. I just saw somebody post that they were having to put Post-it notes on their mom or dad in the hospital saying, if you can read this, call me. So the behavior change of that adult doctor that is not used to having to update a family member, I think is going to be where we have some work to do. I think that once you see the value and the meaning, and again, that Christmas morning we talked about, I think it makes your job more meaningful, and it's not just you're powering through seeing patients. So we'll get there, but it's part of the reason our go-to-market strategy is pediatrics, because it's already part of their workflow, and we've just made it easier, as opposed to introducing that I'm going to have to update that family member.
Yep, makes sense. Well, Mike, we are really looking forward to seeing where Q Rounds goes the next few years. I hope the next time I have any kind of acute care situation that the place I'm going has Q Rounds involved.
Yeah, I appreciate that. I think that if we ask people to reflect on a meaningful health experience in their life, rare is the answer data. Rare is that, wow, this person was so smart. They figured it out. It usually has something to do with a human connection. They sat down, they choked up when they were telling me the story. They called me every day, and so I think that we actually have the ability to re-engage trust in healthcare, because we'll help people connect on that human level and allow people to get the data right, but be able to share it with the people that matter the most.
Well, I gotta say, Mike, just talking to you has made me feel better about the future of healthcare. So thanks for coming on the show.
I appreciate it. Look forward to talking to you next time.
All right.
Thanks, Mike.
Big thanks to Mike Pitt of Q Rounds for coming on the show today. If you want to learn more about Q Rounds and their groundbreaking software, you can check them out at q-rounds.com. And if you're a mission-driven leader or founder looking to grow your impact, you can check us out at stillpointinsight.com. Thanks for listening, and we'll see you soon.